Hey everyone.
Hello, how are you?
Good. How are you doing?
I am all right. Just a note, so we're recording and this will be posted on the committee's webpage. So you can come and go as you like. Don't feel like you have to stay for the rest of the time. But it's your time if you have questions for staff.
Okay, very cool. So gosh, I'm gonna have a lot of ums and so's and likes. Hopefully that's okay with everyone. And also I'll be kind of driving and doing things if that's okay. Hopefully that's fine. Okay, perfect, good. So I think the first am I the only I think I'm the only member, right? Is that right?
Yeah, yeah, you're the only member. So with me is Allison Proud and Joanna Yan from OHA.
Oh, I actually feel kind of blessed. That's awesome. I get everyone to myself. Okay, so I think the first question I have is um, around the social. Actually, let's start with what do we have going on? Can you give me kind of an overview of I know we're in now the fourth month or the fourth meeting of the year. And do you mind kind of first starting with sharing what kind of how things are going to go and what's next and when do we start reviewing the measures and stuff like that? That would be helpful for me if we could start with that.
Perfect. So at this so you've been having conversations at your last few meetings and having presentations on how the program can better incentivize equity and what that means, and having updates on things like the RealD data repository. And then, so that was intentional from the chairs over the last few months. And then at this next meeting, there'll be kind of two parts to the meeting itself. So the first part is kind of bringing those conversations, and to a close is not the right word, but to maybe a pause. So you'll have a legislative update. You'll get a very high level introduction to the CMS core set, knowing that in the future, we'll go more in depth into the CMS core set, and then really talk about having a timeline and also tasks for having equity-based benchmarks. And so it's funny, I was actually looking at slides before this meeting that Allison had put together under Stephanie Fitzpatrick's direction and Jorge Ramirez Garcia's direction about like what are the things that need to happen to get to that place where you could benchmark around equity. So you'll have a conversation around those tasks. There's some slides on what those tasks are, and there'll be time for you all to have a conversation about, you know, what's missing. Are these the right things? What's missing? And then, so you'll have that. You'll also have some conversations. I think you've been talking about, well, for example, when you think about benchmarking for equity, would you have a benchmark that is stratified by a RealD category for 2024? And you'll have an opportunity to say yes or no, we're not doing that for 2024 because there are these other tasks that need to happen before we do that. But we wanted to give you space to just get all committee members on the same page around that. So that'll happen at this meeting. And then also at this meeting, you'll kind of shift from those conversations that you've been having, and you'll hear from OHA our recommendations for the 2024 measure set. So it's really shifting to the work of selecting the 2024 measure set. And one thing that we'll trying to make clear to you all in these slides and in the conversation is that at the same time that the committee is making this shift to selecting the 2024 measures and benchmarks, which you'll do you know, kind of starting at the end of this meeting and really continuing through the summer, is that there'll be work going on in the background amongst OHA staff, as well as certainly in consultation with the committee chairs to keep the ball rolling and hold us accountable to these previous conversations that you have been having. And so how do we make sure frankly, that you've had these conversations the last few months, but that we move them forward, right? That it's not just a conversation, that it leads to action. And that was something that the chairs had talked about with us, needs to be really important. So that's part of having these tasks, so that you're aware that over these next few months, over the summer, you are, as a committee, are going to have to shift. You're going to have to choose 2024 measures and benchmarks, but that there's other work going on in the background. And then after you select 2024 measures and benchmarks, we'll be able to, all the work that's been going on in the background, bring to you all, and you pick that up in the autumn, and think through processes for, identifying measures that are equity focused, where you could really benchmark in a way that incentivizes more equitable care, and how do you identify those measures, that type of thing. So I just talked for a really long time. I'm sorry, you know that I'm not, brevity is not my strong suit, but hopefully that was helpful.
It was extremely helpful. My question was more focused on what's the big picture, right? And what are the actionable things that we need to be focusing on, kind of for this kind of Q2 to the kind of the start of through Q3, right? And then I recall kind of what happened from September onwards, because that's what I'm familiar with. So that was a very, very helpful and thorough answer, which, as you know, I always appreciate. A follow-up kind of question that I have is, I recall reading earlier today that there would be potentially either a refresh or a redefining of a few of the components of the Real D. And I was wondering if, would we be apprised of those as it was being developed, or are we only going to hear about it, come autumn, or come, Q3 time, or not Q3, come the start of Q4?
So with, for those that aren't aware, what Manu is talking about is the Real D, not the Real D dashboard, the annual CCO metrics dashboard that has been, it's stratified. We published it, technically it was late last year, where you can stratify, not all, but many of the CCO metrics by, right now, race and ethnicity and language per Real D designation. But when that came out last year, sorry, I'm just admitting Dr. Fitzpatrick. When that came out last year, we did not have the Real D data repository to use as the data source. So when we published 2022 CCO performance, hi, Dr. Fitzpatrick. We are talking about the annual dashboard. So last year when it came out for the race and ethnicity and language, we didn't have the Real D repository to use as the source. So those data are being updated and refreshed, even the historical data, using the repository data. So they'll be more accurate and more complete, because they'll be using the Real D repository for that information. And that will come out after CCO, we have in contract and in agreement with CMS, the CCOs, we finalized their performance for 2022, and they received their payments by the end of June. And we will publish a report around that time, so folks can see how CCOs did, et cetera. I keep saying the repository. The annual dashboard comes after that. So the one where you can stratify by right now, and then it will be by race and ethnicity and language, and we're hoping for disability. The methodologies, though, are things that have been worked on with our colleagues in the Equity and Inclusion Division, and what is used for the RealD repository. So it's their methodology that is being used to populate the annual dashboard.
Thank you for providing that background. I'm sorry to make you go through that for everyone. Okay, perfect. I know that Dr. Fitzpatrick.
Manu, I can't hear you anymore.
I'm so sorry. I don't know what's going on. Sorry, let me try again.
Oh no, now I think
Oh,
we
it looks
lost
like,
them.
yeah, we lost them.
Oh.
Hello, Dr. Fitzpatrick.
Hi, how are you?
Good. I noted for Manu and I'll note for you. This is being recorded. It will be posted on the webpage. You have OHA staff here if you have any questions or comments. One thing that Manu had asked about actually was kind of what the course of the committee's decisions looks like over the last few months. So we were talking about some of the slides and things that you all will be talking about on Friday, thinking about benchmarking for equity and all the different activities that need to happen first to make that happen. And I was saying how I'm actually looking at draft slides that Allison had put together for that, and they're quite cool. I'm hoping that you like them as well.
Yeah. You guys usually are pretty good in the slide in the figure department, so I trust it.
We try.
It's like, Manu, are you back?
Yeah, can you hear me this time?
Yeah.
Okay, great, perfect. Okay, great. How are you doing today?
I'm good. How are you?
I'm doing really well, actually. Thank you for asking. Pretty excited about the future. I always am kind of excited about the future. So I'm just a little bit more excited about it today than usual. So
Great.
yeah. I come from a provider mentality. And so, I get excited when, like yesterday, one of our affiliated practices, we opened up a 28 chair dental practice. And so I had an awesome time going in, and it houses maybe about 6 to 7 different dentists every single day because of the sheer size of the office. And it was great to see like specialists working alongside general dentists. And I no longer am in an office. I sit behind a desk. And so it was great to kind of feel that energy of excitement of reviewing things and sharing different ideas and discussing different ideas and coming down to the diagnosis and then recommending the different therapy. So it's a part that I do miss kind of in my current day job.
Yeah. But you're still playing a role, an important role, it sounds like. So it's good.
Have you carried on the conversation forward about additional questions that you've asked, or where do we stand right now?
No, so I usually just jump on this call because I feel like other people come with really great questions. And then Sarah talks to me about it like in the chairs check-in, and I'm like, oh man, I missed that. So sometimes I just kind of jump in just to see what other people are asking about and hearing the brilliant responses that come from the OHA team. So
Okay, great. There's actually something that I've been, if you don't mind, do you mind
go
if
ahead, please.
Okay, great, perfect. So one thing that is a definitive known concept is that if you've ever been diagnosed with gum disease, the rate of progression of disease is directly related to your HA1C value being greater than 7.0. And what I've noticed over the years is that there's, and I don't know the right word for it, I'm sorry, the phrase escapes me, but there is essentially 3 different measures as it relates to diabetes as a chronic condition, or maybe it's 2 different measures as it relates to people with diabetes. There's the oral exam for people with diabetes, and then there's also the lower number of those who are poorly controlled, being less than 9.0, the HA1C. And so I think it would be kind of neat, kind of how we have the DHS measure, where and the phrase that I'm coming up with is that it's a rounded measure, meaning that it touches every it touches every single health provider, because it requires achievement by the physical healthcare provider, by the behavioral healthcare provider, and by the dental provider as well. And so was kind of curious, kind of your thoughts about the idea of maybe combining that measure into one. Or what do you think? There may not be an appetite for it, but just from an interest perspective, is that something that, or what are your thoughts about it?
Is that to Sarah?
No, this is to you.
Oh, it's to me. It's to me.
Yeah.
Yeah. Yeah. I mean, it's interesting. I think what I think about is, and I know it's expanding or increasing, but I guess I get a little bit concerned about the lack of integrated medical and dental practices, even though I know that those numbers are increasing. And so I also worry about, even though they're all, Medicaid beneficiaries, I just worry about linking two things in which, for various reasons, one might be more likely to happen than the other. Whether that be going in to get your A1C test, or whether that being going in to get your dental. And I think unless it is an integrated medical or dental facility where both can happen, or both are more likely to happen, or one happens and then one can provide a reminder for the other to happen, I think I would just be a little bit concerned on CCOs being able to meet a combined metric, even though I totally get it and see the importance of the integration, if I'm making any sense. So I like it, I get it. I just worry about, I guess, the practicality of it for various reasons. Does that make sense? And then I don't know from a CMS standpoint, if they specifically have these separate for a reason either. So.
Yeah, that's a good point. I agree with your second component. I don't believe there are any adult CMS measures that we know of around oral health. But your other component around, let's call it a co-located model, where physical healthcare providers and dental health providers under the same roof. That, of course, is only present in certain types of PCPH models or community health centers. But really, that's what I view as when we think of integrating and coordinating care. It's really driving these very loosely connected healthcare providers and driving them for better care delivered to the underserved populations. In this case, it's the Medicaid population. So I think I hear you that it's, it likely hasn't been done before. Some would be of greater success than others. And then there are other avenues of support around, the HA1C value being measured at the point of care in the dental office, which has been allowed in the state of Oregon since 2016 or 2017. And so we do have a few dental providers that perform the HA1C test at the point of care within the dental office, because as of 2018, that's when the diagnosis of gum disease has shifted into this idea that we now think of how cancer is diagnosed, where you have stages and grades. And so I think it's about kind of focusing on how do we create a more integrated system, even though your physical healthcare provider is not directly next door to your dental health provider.
And do you think by having a combined metric that would drive or increase this integration?
It would require that integration.
Yeah.
Right. Much the same as we're trying to, whether it's immunizations, right, or anything else, it drives for that integration forward, and it's transformative enough that
I don't know. It's just what we do in Oregon, right? We have to advance the puck, right? We can't just let, let things be. And we shouldn't, because we're all here to improve the system more than
Right.
what it is.
Right. Agreed.
But Sarah, to Dr. Fitzpatrick's point, you agree that, I just want to confirm that second point that she made around that on CMS adult measures, it's not tied together. Is that correct?
Yeah, I guess I'll say a couple things, because I do have a question on what is meant by a combined measure, because there's a couple ways you could do it. If you mean literally a combined measure where you're calculating this, so kind of like the ODHS custody measure, we have one denominator, we literally look at those individual kiddos and youth, and we see, did they get their physical, mental, and dental health assessments? Like you track, and to meet the measure, you have to meet all those for that individual person. For the HbA1c poor control measure, that right now, that is an EHR measure. And oral evaluation for adults with diabetes is a claims-based measure. And for EHR-based measures, we don't have member level data. So we would never be able to link those and do something like we do for ODHS custody. And so that's one reason we couldn't do it, because we literally don't have the data. But even if we had the data, there's the whole issue of like measure stewards and who owns these measures and if they would let you modify their intellectual property. So that's one thing where you couldn't create one measure with the same denominator, if that's what was meant.
No, what I meant was actually coupling, like we do with the preventive dental service measure, where we have 1 to 5, 6 to 14. I was actually looking at it. Why don't we couple that, so that then, in order for the CCO to achieve the metric, they have to hit both one and the other. That's the way I was thinking about it.
Yeah, that's what I was gonna say. So that would be, the committee could do that. You could bundle measures it's in terms of your benchmark setting, right?
Yes.
You could look at doing that.
Bundling was the word, not rounded. I don't know where I got rounded from. Bundled was the word. Okay. And I cut you off, Sarah. You were going to say additional pieces, I think.
Oh, no, I don't know if Dr. Fitzpatrick, with your comments, if you were thinking about like making it as one measure or the bundling.
No, I think I was thinking about it as bundling as well. I was just thinking about the practicality of it, but I also hear Manu saying and agree with, and I think we've said this about other metrics before too, that sometimes metrics drive what it is that we need to see or what needs to be happening in terms of improving quality of care. And in this case, integration of medical and dental care for folks. So I get that too. But yeah, I thought about it as, I think kind of how we're doing the meaningful language access, right? There's a kind of a qualitative and a quantitative kind of two component piece, and we set benchmarks for both. So that's kind of how I was thinking about it when Manu was describing it. Even though these would both be quantitative, so.
So there was a proposal, I will tell you, in terms of bundled metrics. The committee did not vote for it, but there was a proposal from OHA a number of years ago so there's the kindergarten readiness, the 3 measures. They're not, the committee hasn't bundled them in terms of benchmarking, but so it's the preventive dental metric for the younger age group, the well child visits, and then the social emotional health measure. And when the committee was considering the preventive dental measure at the time, there was a dental sealants measure for 6 to 14-year-olds. And the reason the kindergarten readiness work group hadn't proposed dental sealants, right, is because young kids don't have teeth to seal. And so they added to the preventive dental, they added the older age group because they wanted to have that, they didn't want to retire the sealants measure for this older age group and have nothing that would cover them. So that's why, And so there had been a proposal at that time for the bundle those two measures in terms of your benchmarking and have preventive dental for the younger kiddos and sealants for the older kids. And so what they then decided to do was still have kind of a bundled measure, but it's the same measure with two different age groups.
Okay.
Well, the other reason why I'm bringing it up is, back in 2019, we were sitting at targets that were around 30% for adults with diabetes who had a comprehensive oral exam. And looking at capital data, we are last year, we were around 20%, and which is less than where we were able to hit that in 2020 or in 2021, sorry. And so in an effort to think about how do we drive for better utilization, because I do believe that it needs to be above 30%. Well, how exactly do we get there? And so I think by breaking down, these clinical silos that exist, whether it's from a health information technology perspective or from just the simple fact that, when I used to work in a community health center, the healthcare providers don't communicate with each other, even though it was all under one roof. So how exactly do we, can that be driven forward is really the concern that I have. And that I was looking to address through the power of the metrics and scoring committee. But I'm a bit of an idealist. So, and I know that about myself. So don't worry about it. I don't feel bad if things don't go a certain way. I was like, okay, that's okay. So I know how I am.
I think that's a good point. And I think sometimes what I struggle with when we try to think about how the metrics that we choose as part of the incentive program and how we do benchmarking and setting benchmarking to drive change, there's all these other things that have to happen for the change to actually drive. And so I think I feel like a number of times I ask about, well, what are the resources? What's the training? What's the learning collaboratives that are available to CCOs and to health systems to be able to figure out, in this case, how to start or how to do or how to enhance medical dental integration? What are different ways in which they can look if you're not under one roof? Who is in your area to partner with? How do you set up that collaboration and that and the technology probably still required to be able to have that integration be facilitated? And so I think sometimes, yes, I'm like, yes, like incentivize change, but are we incentivizing all the other elements that need to happen for change to be fully realized?
So some of the things that Capital utilizes that other DCOs also utilize is this concept of co-locations. And so currently we're contracted with, I think, 40 to 50 different types of healthcare providers, where we have a dental provider going into the office 1 day a week or 2 days a week, whether it's a behavioral health center, pediatrician office, an endocrinologist office, an OB-gynecologist office. And more recently, we received a HRSA grant to co-locate dental providers within hospitals as well. And so, it's really about, this concept of, how do we integrate beyond? And you touch upon it very, very well and eloquently that, if they already don't exist in a subleased kind of or a leased space like that, where we have PCPHs or community health centers, what other forms are out there? So I think that's definitely one step that would get us there. But just kind of thinking out of the box a little bit.
Of course, yeah. Hi, Jorge.
Hi, Jorge.
Hello. I wanted to check and see how things are going.
Manu and I are talking about oral care, dental care access, and And possibly even floating a motion to bundle our HbA1c and our oral care for diabetes metrics.
That
I
seemed
can
like
see the value
nervous.
of that.
That seemed like nervous laughter, Dr. Fitzpatrick.
Well, because I'm also recognizing I'm being recorded, so I don't want anyone to hear this and be like, "Oh, they're gonna do that." Like, just summarizing the conversation that we're having.
That's a good point. That's a really good point. Yeah. Do you have any clinical questions around it? I'm more than happy to dive into the fun details if you like, or answer any dental related questions as well, if I can help kind of support an understanding of a knowledge base of oral health.
I mean, I was wondering in terms of, and Sarah, you were just kind of talking about kind of some history in terms of metrics around dental care. Has there ever been any other, I guess, kind of more general dental care metrics, particularly for adults, and just in terms of, there's at least a cleaning and screening and things like that once a year, or how many people get, some of the basic dental care, especially since it can be preventative for chronic conditions. So just curious.
I think Sarah could better speak to the history. I only joined Capital in mid of 2020, and so my understanding of anything before 2020 is extremely limited. So Sarah, would you be able to chime in on that?
Yes, I'm just looking at the list. So having oral health measures actually came later because oral health wasn't included in the global budget until 2024. So like even in the measure we have for kids entering foster care, the oral health component of it wasn't included in the first year of the measure or the program. It was added later. So I'm just looking. So we have, for kids, we've had the children and youth entering ODHS custody. So that includes an oral health component. We've had previously, there was dental sealants on permanent molars for children, and that looked at 6 to 14-year-olds. No, actually, yeah, looking at this. So oral evaluation for adults with diabetes is the first adult and only adult oral health measure that's been included in the program. And I'm remembering when it was so that was added in 2019. And to Manu's point, and you'll talk more about this on Friday, the CMS core sets currently do not have adult oral health measures because a lot of states don't cover adult dental care, but we do. And I think part of why there are the Dental Quality Alliance, which is part of the American Dental Association, does have a set of measures that it stewards, and it includes both child and adult oral health care. I'm thinking back in 2019 when oral evaluation for adults with diabetes was added by the committee. I think one of the reasons that was chosen was a desire for integration across dental and physical health care, and the hope that that measure could help foster some of that. I think I shared this with you, Manu. We have, even with that measure, thinking about it as an integration measure, we have had questions from CCOs previously about, well, who, from a clinical perspective, like who is accountable for that? Like the whole program, right, of CCOs, but like at the clinical level, who's accountable in there? Is it physical or is it oral health? And our answer was it's both. That they're meant to be working together to help these people manage their diabetes, and part of managing your diabetes is your oral health care, and vice versa. That was I am always long-winded, I'm sorry. My long-winded answer to your question.
I did want to share for Dr. Fitzpatrick, Dr. Rivera, as well as the recording, that next week is the annual conference of the Dental Quality Alliance. set up by the American Dental Association, and I will be in attendance for that. So any information that can be gleaned around adult oral health measures, I'll be happy to share that and report that to the team or to the group.
Thanks, Manu. That'd be great.
So if it's okay, if I could shift the conversation away from oral health, which is kind of funny, I know, because I'm the oral health person. But the question that I have is, I believe Stacy had shared either at the last meeting or the meeting before that the intent of the health equity or the new metrics and scoring evolved of health equity would include what we can call it a simple majority of community members. Has that been approved and passed through legislation? Or are there other things that we need to deliberate on at this level of the metrics and scoring committee?
Nothing has passed. Nothing has passed through the legislature, and actually there are amendments that are being considered that Stacy's going to give an update to you all at the meeting on Friday. So yes, session sine die for session is June 25th. I have it on my calendar and I am looking forward to it. So sometime before then we will know what happens with this legislation, whether it passes or if there are changes and those pass, or if nothing passes, we don't know at this point. But yeah, Stacy will give an update at least on where things are right now on Friday.
Okay, and so after the update, is there anything that you would like of the metrics of the scoring committee to deliberate on or support or to provide recommendations of, or would it just be a kind of unidirectional update?
It's an update, and then you all can have conversations and ask questions. I mean, at this point, it's really with the legislature.
Okay, great. Thanks for letting us know or letting me know.
Jorge, did you have anything?
I think, well, first of all, I wanted to make sure that I got a sense of the topics that are in the minds of the committee, or those of us who attend. It's great to see you and Manu, and to hear about importance of integrating explicitly in planning for oral health. The work of the composition of the committees and its corresponding value that it brings to health equity. It's also great to get an update on important work in progress, and really appreciate the work of all involved and of health analytics to keep us from January. Okay, we need to have our committee know what's in store. And now it's like we're approaching June 25th. And this is where we are. So I think that speaks greatly of the continuity and having our committee stay abreast. And thank you, Manu, for the way you approach that in terms of, okay, so how can we be of good service there in terms of following up, and what things can we bring to the table, or is it a matter of monitoring and being well informed, which sounds more like the latter. In terms of seeing the agenda, reviewing it, I'm wondering how we can be as prepared as possible to launch onto our timeline for decision making in terms of selection. I myself was going through okay, so we're going to really start doing the work there and going through a process of, okay, so what are the degrees of freedom, within the set that we have? It's a little bit of a nerdy statistical term, but it basically means, okay, do we have any room to bring in new measures in addition to what we have, or does that mean that we need to de-implement something to make space for anyone new? So I was working through that process and thinking about how to structure that. And we have all that information, but it might be good to I certainly gonna create a summary of sorts, but to have a summary, okay, well, here's our total number of measures, and are we allowed to go over if we wanted to or not? What are the parameters? And once we have a range of total measures, then, okay, which ones are, don't touch this, which really means, if we have, like, for example, if we have glide path measures, we're not going to implement those, under tracks, right? So those are really, pardon the don't touch expression, those are really off the table. And, so just a way to start working through that process, and maybe, for those who are super well-versed, I'm certainly looking at Sarah, it's like, well, I know that, but just to bring the group in line and see, okay, so here's our total, here's, of the table, and it really leaves us with how much room do we have to change the current set, basically, and not expecting to arrive at a concrete answer, in our meeting this week, but at least to bring the group in alignment and having a range. Okay, here's a range for us to. So that's really where I came into our meeting today. And of course, once we work through all of that, then we have the important issue of the health equity, how to continue boosting, if you will, embedding more and more health equity processes to the value-based performance program and portfolio measures. Yeah, I hope that summary makes sense, and I wonder if you have any reactions.
Yeah, I'm glad you said that, Jorge, because now I'm having a flashback and remembering, and I can't remember when you joined in, Jorge, but I feel like the least 2 years I remember us doing kind of like a survey as a committee, rating kind of was it, Sarah, like the importance and which and transformational level of each metric for us to then kind of come down and start to narrow down which of the number of metrics, which are the metrics do we think are, kind of fit our definition of transformation? And I think it was importance, but you would know better the domains there. And then as a committee, then we kind of, OHA kind of, analyzed that survey information and then kind of helped us to then guide us on kind of not necessarily ranking, but thinking about what are the metrics we should definitely include in an incentive program going forward before we then proceeded to benchmarking. That's what I recall.
Yeah, so I can address a few things. So in terms of, Jorge, your question about is there a cap on measures? No, you are the metrics and scoring committee. You could have a set of one measure, you could have a set of all the measures on the health plan quality metrics committee menu if you wanted, and there's 50 some. In terms of precedent with the program, the greatest number of measures that have ever been included is 19, and the fewest measures, I believe, is 13. Maybe off on the 13 measures. When there were 19 measures, that was for 2019, there was considerable concern about that. that was too many. There was a lot of public commentary from CCOs that was too many to focus on from a quality improvement perspective. And so that led to a reduction in the number of measures in 2020. But currently now there are 15, but you are not, there's no magic number. The recommendations from OHA that will be coming out for you all is to just roll over all 15 that are currently in the program for 2023 into 2024. That's our recommendation, and I will formally provide that to the committee on Friday. And our rationale for that includes that there's been a lot of upheaval in the system, and that it's not a time to make big changes. We also think all 15 of those measures are important and need some time for CCOs to make some really sustained efforts on them. There has been a new measure in every year of the program for the last 3 years. So we think it's important to have some stability, and we also think all 15 of those measures are important. But that's the OHA recommendation. You are the committee and you make your decisions. Dr. Fitzpatrick, you had said about what had been done previously. Actually, 2 more things before I get into that. The other thing that we had talked about with Dr. Fitzpatrick and Dr. Ramirez Garcia is having, like, how long in the past we've had the committee select a draft set of measures and then waited a month before it was voted in to give an opportunity for folks to give public comment, for the committee to just sit back and reflect. But it seems to me like there might be some appetite from the committee to have a longer time period, where maybe you would have your draft set out and maybe have 2 months to allow for more public comment. That said, it would have to be built into, at some point you have to make final decisions on this set, so then you can shift to benchmarking. And benchmarking, as you all know from last year, like, that takes a long time and that's really hard. So it kind of depends on, I think, the appetite for the committee in terms of changes that you would want to make and the dialogue that you'll have on Friday. Stephanie, you had mentioned in previous years we had done a survey of committee members, and so what we did is we took the current measures in the set, and there was one of the committee members had wanted the committee to consider adding another measure. So we have the current members in the set, and then this other measure that one of the committee members had wanted to be considered. And we had asked members to rate them on two scales. So one of them was the committee has, and this is in your consent agenda, they have a working definition of transformation. And it's linked with the health equity definition. And so we'd had committee members rank them. What do you think this measure, after you looked at it and looked at the specifications, how, I think we used a Likert scale, like how much does it align with the transformation definition? And then the other thing we had them look at is, okay, so there's that piece. And then we looked at how much do you think it, like, agree that it should be in the set? And that was another scale. And it was interesting when we then just sorted them, and they generally kind of aligned. I mean, it wasn't exactly 1-to-1, but they did kind of align, and that helped the committee then to make their decisions about the set for, my goodness, what year was that? I'm sorry, I can't remember what year we had done that, but
I feel like I've done it twice. I feel like I did it when I first came in, and I did it the second time around. So yeah, 2021, 2022, I guess. I don't know, something, or 2020. I don't, I came in 2021.
it wasn't, I don't think we did it. Maybe we did it. Maybe we did it last year. Sorry, it's like the last 3 years.
I know. That's why I'm like,
But
when did I come in? I don't know. Yeah.
Time. So at your meeting on Friday, this is one of the things at the end of the meeting, like, we'll give our staff recommendations, and that's something for you all to discuss, is what do you want your measure selection process to look like? The other thing to note is before your May meeting, you will get what we call our measure selection packet. So that will include the specifications, the technical specifications for all of the current measures. It also has a brief overview of all of the current measures. It includes, the committee does have a measure selection criteria. You're not held to that. I would advocate to you and others that the measure selection criteria does need to be revisited, because I don't think it necessarily aligns with health equity. I will just state that, but you have criteria to think through. There is a checklist that the committee considers if you're thinking about retiring a measure, so that's included in there as well. And then the other thing it will have is for those current measures performance history. So you can see some of that. We'll only have what you would get. The most recent year we'll probably have is 2021. Within the next 2 months, we'll be able to update it for 2022. But you'll have this, I mean, it's really long. Like, think of all those things, like it's like 100 pages when you add the specifications, but then it's there. So you have one document to go through to familiarize yourself with the current measures. But that's something that you'll have, and we're going to try to get that to you at least 2 weeks before the meeting. And then we would have we'll have another office hour too if folks have questions about specific measures or anything in there. But yeah,
That is an excellent summary.
Want.
Really appreciate it. As we come on board and for a full year in my case, and I've seen as you provide a summary, all the elements come back to mind, and I remember seeing the grid and seeing this and that, and so really appreciate it too. To the that synopsis, it's very helpful. And it's going to be a very good pivotal meeting because we can incorporate our material from that we cover in 2023 and its implications, and then just really launch this process and look for the next couple of months or so to start honing that in.
And if it's helpful to have a survey, we can certainly do that for you all. It just would help us to know at the next, like on Friday, if that's something that you all might like and how we would want to structure it, just so we can build it and get it out to everybody, so you have sufficient time to answer and we have sufficient time to analyze it.
I'll certainly bring it up, and I think it'll be worth having a discussion about the pros and cons of that approach, just because I'm also hearing you saying, considering how much time we try to provide for public comment, a month or 2 months. And certainly if we're doing a survey and then we have to come back and digest the survey results to then decide what kind of the final list of metrics are, and then that goes to public comment. I'm not saying either or, but I'm just saying I think it's worth us thinking about both sides of multiple approaches and strategies as we make our decisions, just to make sure that we can capitalize on as much community input as possible before getting to the finalization of the metric list, and certainly before starting the benchmarking process.
I think as your staff, I'll just say this, it's I keep getting a lot of questions of like, well, what are we doing in May and June, and what's it going to look like? And my answer is, well, I don't know, because it depends on having a as staff. Selfishly, ideally, it would be wonderful if we could get kind of a temperature check from you all in terms of what you think about the staff recommendations, because that if bigger changes are made, that's like a bigger thing, right? And I think would necessitate taking more time. Not that I'm saying if you went with the staff recommendation that you shouldn't have adequate time and allow public comment, because you totally should. But it would, like if there are other measures that folks are interested in, or if there are measures that you're thinking of retiring, like every single measure has an advocate. And so those folks would need to have time, would need to be know and have time, and you might have specific questions, and that just takes, the more time you can give us as staff and even beyond staff, certainly the public, more importantly, if there's any big changes, the better.
Got it.
That makes sense to balance having a thorough, inclusive, participatory process, but then feasible, right, for a time frame. So it's a balancing balancing act that we have ahead.
And the other thing too, like there's this shift. So you're going to start selecting the 2024 measures. From the 2025 measures, I'm thinking through the CMS core set specifically. What you were saying just now about a participatory process, I think that's something that it's best practice, but also by necessity, it's kind of like you'll almost have to start doing that for next year. Like you could almost start building the set earlier from the beginning of your conversations versus I think the way we've done it to now, because there's a set, and so you have to consider these measures that are included. Anyway, that's for a conversation for future, but
Yeah, that makes sense. This year was not necessarily unique, but I think important in terms of we needed to wrap our heads around and start to discuss this health equity benchmarking. And so there was a lot of kind of foundational knowledge and work that we had to hear about. But certainly early next year, how those first 4 months of the year could look a little bit differently and could move the process in terms of establishing a metrics list a little bit sooner, maybe.
and I'm conscious we are over time now. If anybody has any questions for staff, I'm happy to stay a few minutes and answer them, but otherwise.
No, as always, thank you all so much for your brilliancy and your support in this important work. So thank you all.
Yes, thank you for making the space for this important discussions to get us well prepared. Thank you. Everyone have a great evening.
All right.
You,
Bye. Have a
you
good
too. Take
evening.
care. Bye, everyone.
Bye.